Yeah, so I'm Paul Campbell. I have two jobs. My first is that I'm a psychologist by trade, a clinical psychologist, and I work for what was Five Boroughs Partnership, is now North West Boroughs Healthcare, and I lead their adult IAPT services. So I've been working on IAPT since before IAPT, basically for about 10, 12 years now. My other role is as clinical lead for the Strategic Clinical Network for Greater Manchester. So that's a sort of advisory type role on adult IAPT issues. Could I just do a show of hands? Could you put up your hand if you work in IAPT services or your interest is in IAPT? Okay, so very few. So most of you don't know what IAPT is. So one thing I should say, I've been married 10 years and I'm not used to talking without being interrupted. So feel free to interrupt me as we go along. Probably better if you ask questions as we go along if there's something you don't understand. So anybody, if I talk about ACT and I use terms you don't understand or you don't know what I'm talking about when I use certain phrases, let me know and I'll explain it. But I'll try and keep the jargon out of it. So today's talk is about our journey as a trust in using Silvercloud. So we'll look at the reasons why, the key drivers or reasons why we chose Silvercloud or chose to start using digital technologies. We'll look at the lessons that we learned as we rolled it out, how we're doing at the minute or how Silvercloud's doing at the minute, and we'll talk a bit about what we plan in the future and the possibilities. So one of the reasons we chose to use digital was that, as we know, it's in the plans for IAPT. Well, what I should explain what IAPT is. It stands for Improving Access to Psychological Therapies. It's a NHS England or Department of Health project that started around 2006, 2007, and an economic argument was made by a guy called Lord Layard, who's an economist, together with a psychologist called David Clark. And they put the argument that there are so many work days lost to anxiety and depression or common mental health disorders that if you paid to roll out effective therapies like CBT, if you paid for those in advance and made them easily accessible to everybody, then they would pay for themselves in the long run, in that people wouldn't stay off work for as long if they're anxious or depressed, and people would come off incapacity benefits having had their depression treated. What they found was, so they spent in theory about 400 million training therapists across the country. And what they found is in about year 3 of IAPT that the Department of Work and Pensions budget had come down, or their spending had come down by about 400 million. Obviously you can't say that's due to IAPT, but they made the argument that the therapy was paying for itself, so much so that the Department of Work and Pension is now paying for people to work in IAPT services to help them back to work and things like that. So that's the main tenet of IAPT, was to improve access. The other key driver for it was to improve quality. It used to be that people got their talking therapies from psychologists, and as I said, I'm a psychologist, so I can slag them off. What you got was whatever the psychologist wanted to give you when you got to your psychologist, and when services were trying to work out whether or not their services were effective, the people they asked were the people who delivered the service rather than the people who received it. So the second big change in IAPT was that services had to, in exactly the same way across the country, measure their effectiveness by asking their patients whether or not their symptoms were any better. So every service has used the GAD and the PHQ, which is a measure of anxiety and a measure of depression. Is that okay? Any other questions? Any questions on IAPT, or is that clear enough? When I talk about IAPT, that's what I'm talking about. So one of the things about IAPT is that you can only use NICE guideline therapies. So we can't use things like hypnotherapy, even though some people find it effective. If it's not in the NICE guidance, your local IAPT service can't provide it. In the NICE guidance for depression and anxiety, they suggest a stepped care model, and that's basically starting with the least intrusive intervention first, especially for those people who are mild to moderate. So that's what Silvercloud provides for us, is a way to roll out what we call low intensity therapy. Some of the other reasons why, so we used it because it was in the NICE guidance. It's in the national plan for IAPT that we use more digital, and mental health generally, that we use more digital technologies. The other couple of reasons we use it is we were always quite squiffy about using technology and thought people who are anxious and depressed won't have access to computers, won't want to sit in the room and talk to somebody. And when we pitched it to a GP practice it was in Kirby actually, which is quite a deprived area in the outskirts of Liverpool, they said our patients would love it because we recently introduced a system where we have an online doctor system where they can put their symptoms in, and it would tell them when they could have an appointment or if they could have a phone call with a GP. And what they found was the feedback they got from their patients was they preferred to interact with their surgery electronically rather than phoning up. Well, we all know what it's like phoning a receptionist in a GP practice to try and get an appointment. You have to tell them everything that's been wrong with you for the last 6 years before you'll even get onto the appointment book. So the patients, even in a very deprived area, liked a digital interface. Also, we started to treat a lot of people with long-term physical health conditions. We know that people with, for example, people with diabetes are twice as likely to be depressed as people without diabetes. Lots of them have mobility problems. We also know that people with chronic fatigue are more likely to be depressed than other people, and less likely to seek help, and often less able to get to help when it's provided. So we had our long-term condition population in mind. So those are the main reasons why we chose a digital platform. We also ran a project where we basically reviewed all the evidence for the digital providers that we could find, and Silvercloud was the best one, to be honest. They'd quite good research methodology, and when we asked digital providers to give us things like their recovery rates, some of them gave us figures that didn't sound right. And when we dug deeper into them, we'd find that they weren't actually talking about recovery rate the way we were talking about recovery rate. But with Silvercloud, they basically offered us access to all their raw data and all their trial data. So it was quite easy to clinically justify it because it was the most evidenced digital intervention that we could find. And I'm not just saying that because they're sitting in the front row, that honestly was. So what we did was we implemented a pilot probably about a year ago. A year and a half ago, we started actively using Silvercloud. So some of the challenges that we had. So I should mention what happened. So when patients come to us for asking for a psychological therapy, we assess them, and if they're appropriate for psychological therapy, as in they're anxious or depressed and they want to engage with a CBT type model, we offer them either a group or a course, Silvercloud, which is online, or face-to-face therapy. Any what, sorry? Our services, if someone has significant drug or alcohol problems, we ask them to go and get that seen to first. Oh, right, okay, yeah. Well, most people that we see are already on something. But what NICE guidance says is if it's sub-threshold, sort of mild depression, don't try drug treatments yet. Try a bit of talking therapy. And if that doesn't work, then introduce some drug treatments. But most people who go to their GP are given a drug and a referral. So most people, we wouldn't ask them to go to their GP and get something before they start. So everybody's offered Silvercloud, a course, or one-to-one therapy. And what we find is most people choose one-to-one therapy, certainly in the early days of Silvercloud. But we've been using it about a year and a half now, and what we're finding is that gap's narrowing. So lots and lots of people are choosing Silvercloud and course interventions. So courses like Living Life to the Full and those sort of low-intensity, well-being type models. People are choosing those in Silvercloud a lot more than they used to. So that's when Silvercloud's offered. If they choose Silvercloud, then we get somebody to give them a call, set them up on the system, show them how to use it when they're there, and then they get weekly online reviews. So the essence of Silvercloud, jump in here, Claude from Rome, is that there's an anxiety package, there's a depression package, there's various packages for common mental health disorders, panic, things like that. The person is allocated a therapist still, and they're given their own part of the website that they can log on to securely. And then every week the therapist says, I'll be on at, say, 11:30 next Wednesday morning to check how you're doing. The person...
Caveat that it doesn't have to be time specific, so that's the benefit to the online review. So you would commit to a day, so you might say, okay, I'll give you an online review on a Thursday, which gives you a bit of flexibility then as a supporter, because it could be 10 a.m, it could be 2 p.m,
that's a good point. Also, the client isn't online when you do the review. The client goes online between the reviews, does the work online, and the therapist goes on and can see exactly what they've done online. And that happens for usually about 6 to 8 weeks. It takes them to work through the modules. And then at the end, what we do is, if you're not recovered, then you're offered face-to-face therapy. If you are recovered, you're discharged. And if people drop out halfway through, so they log on 3 times and then haven't logged on in a couple of weeks, usually get somebody to give them a call and say, "We notice you haven't been on. Is it something about the package, or is it something about just, are you starting to feel better or starting to feel worse? What is it?" And then we can regroup at that stage and offer them something else. Might offer them a course, or might offer them face-to-face, one-to-one therapy. So some of the issues we found when we started the pilot, a lot of the resistance didn't come from patients, it came from therapists. The "it'll never work" brigade, and this isn't what I signed on for type thing. Therapists value what they do greatly, and anything that's seen as watering down what they do can be quite difficult for them to manage. So what we did was we didn't have therapists who did solely Silvercloud. So they'd maybe do half a day or a day a week Silvercloud stuff, and the rest of the week would be their usual therapy type stuff. Also, they were quite suspicious, as most people are, quite suspicious as to whether it would work. And one of the things that people were concerned about is, what if someone wants to do it but isn't very good at computers, or doesn't have a tablet or a smartphone, or doesn't know what a mouse is and doesn't know how to work it. The way we get around that is, if it's just a computer issue, then we'll give them access to a computer. In the NHS, there's a lot of hot desking going on at the minute, so we have patient hot desking as well, where they can come into the unit, have somebody help them sign on if needs be, and basically helps them manage the computer. It's not a therapist, it's just somebody who knows how to switch on a computer, log into the Silvercloud and use a mouse and a screen and things like that. We thought that was a better option than giving every patient an iPad, because then you'd lose all your economic advantage of doing it online. Also, it took the PWPs a while to get their head around the Silvercloud program and get used to using it. Also, one of the problems we had in the early days was PWPs seeing Silvercloud as therapy. One of the reasons, if we're honest, we introduced it is because it's very, very efficient. So our PWPs were seeing 5 clients in a half-day session, face-to-face. Silvercloud models, we predicted that using Silvercloud they could see 10, they could basically do 10 online reviews. What happened in the early days was they just kept seeing 5 and assumed that that's my caseload, so that's my caseload. And part of it was about them getting used to using the system and not feeling comfortable with it. And what we find now is the average is about 12 reviews in a half-day session that people are doing at the minute, and not feeling rushed. There's also a system called Prism, which we were about to introduce. And in IAP terms, when doing IAP therapy, there's lots and lots of data you have to report on every session. And we use a system called IAPTIS. Other systems are available, like PC Mist and other things. But basically, Silvercloud talks to our patient management system. So when a therapist goes on and does a review, they don't have to copy everything from the review into our patient management system. It's automatically copied into the patient notes. So all they have to do is review the online stuff. There's no admin basically for them to do. So that's helped with capacity and things. And we find that they're saying 12 rather than 5 in a session. With regards to who's suitable and who chooses online therapy or CCBT, this is a list of sort of an ideal scenario or an ideal client who will benefit most from Silvercloud. So they have to be able to formulate and be able to develop goals for their therapy. That if they don't have a clear idea of what they want to work on, that doesn't stop them using Silvercloud. All we do is, in their assessment, we help them to figure out what it is they want to work on. As you would in therapy, lots of people come to therapy and you say, what do you want to achieve? And they say, I want to feel better. They've no idea of measurable goals or things like that. And part of the therapy is about helping them to develop measurable goals. So it's the same as Silvercloud. You do that in the assessment with them so that they go on to Silvercloud knowing what it is they want to achieve. They need to be motivated, but they don't need to be as motivated, or they don't need to be more motivated than any patient who comes along for therapy. What we find is we have the usual range of people who take up Silvercloud. There's not a specific group that opts for Silvercloud. In theory, they need basic IT literacy, but as I've said, there's ways around that. If someone truly can't engage with a face-to-face appointment and wants Silvercloud but doesn't know how to use a computer, then we help them use a computer. One issue with it is that you do have to be able to read, to reading age of 14. Also, if English isn't your first language, it can be very difficult for you to navigate through Silvercloud. So we usually find that those people choose face-to-face therapy rather than using Silvercloud. But having said that, there's not a lot of jargon on Silvercloud. You don't have to understand deep psychological principles to be able to use it. It's quite user-friendly. Lots of services who use it base it on client preference, so the client has to choose it. But that's quite often an informed choice. So if you say to someone, do you want face-to-face talk and therapy with a therapist, or do you just want an online thing? They'll choose therapy. And what we've found is, as our therapists know more about Silvercloud, they're better able to verbalise the advantages involved in Silvercloud. And that's why we found more people choose Silvercloud now than they did at the start of the pilot. Also, those people, we find it's good for people who work and people who don't want to ask for time off work. We also find it's very good for people with long-term health conditions who, for example, the time when their brain is most active is 3 a.m. And not at 2 p.m. on a Thursday when you have an appointment. And they can log on basically and do their therapy appointment or do their therapy work anytime. And we find that long-term conditions people probably benefit more than the generic population with this, because they have that added, they get rid of that barrier that wasn't in front of them to accessing therapy. And as I say, those people with practical barriers to accessing therapy, it's good for them. Any questions as we go along? Feel free. So some of the things you need to do in introducing this is to build trust. We all know, we've known for years that the active ingredient in therapy is the relationship between the therapist and the client. Some of Bruce Wampol's work in the last year has shown that it's not as clear-cut as that relationship has to be based on a personal tone, and also that the client believes that the therapist knows what they're talking about. So a nice therapist who you really like isn't as effective as a nice therapist who you think really understands your problem and really knows their field. So that myth that all you need is the therapeutic rapport, we've lots of evidence now to say that that's not enough, that the content of the therapist's knowledge needs to be there as well, and the client needs to be comfortable that the therapist knows what they're talking about. But people often think that an online package is sort of impersonal, but our therapists can tailor it. And I'll show you an example in a couple of slides' time about a tailored message to a client. We also, as with any therapy, we need to manage people's expectations, that this is a low-intensity therapy that works for most people, but you may need something else afterwards. But the skills that you learn in this therapy you can bring to any subsequent therapy you have. And we also need to help people facilitate the use of the platform. So as I've said, the platform can be quite personalizable, and I don't have much direct knowledge of using the platforms with clients at the minute, but the package can be tailored to the person's problem. So if the person has panic problems, the therapist opens up a panic module for them. If they find out that it's actually depression that they're working on, then they open up a depression package for them. So you can tailor the packages to people. The therapist goes online, as I say, each week, reviews how they've done, and can leave messages for the person. And we find that therapists prefer to personalise those messages. You could do a copy and paste, well done doing module 2, move on to module 3. But what we find is therapists don't like doing that, and they prefer to talk to the client. So I'm assuming you'll get the slides and you can read this, but just gives you an idea that therapists go on and say, Jim, you did really well this week. I noticed you struggled with that bit of the module, and you gave a few answers and said that you were struggling with it. They can leave a bit of personalised advice. So when we say no stimulant drinks of an evening, did you know that tea is a bit of a stimulant, or did you know that smoking just before bed might actually be keeping you awake? Those types of personalised message, and you're doing really well, and the next module I'm going to open up for you is quite a good one, and I think it'll really help with some of the things that you say. So it can be completely personalisable. The other thing that people worry about with an online package is risk, and with Silvercloud, in IAP services, we use the patient health questionnaire to measure people's depression. And the last question in that is, have you had thoughts that you'd be better off dead or hurting yourself in the last couple of weeks? And then they rate how often they've had those thoughts. Silvercloud adds a bit more to that. So if people say, yes, I've had some thoughts, it then asks about plan, it asks about intent and history and things like that. So there's actually a better risk assessment on Silvercloud than there is in the IAP minimum data set. So much so that we now use Silvercloud's risk assessment in our face-to-face therapy. And if someone flags up of, I have actually been thinking about it a bit more than usual, and I know how to do it, then both the therapist and someone we assign in the service who monitors risk is emailed it right away, just to let them know that this person's put on something that they might want to check out with regards to risk. And the way we handle that is somebody gives the person a buzz, says, I notice you're struggling with risk. I notice in your Silvercloud you'd said you were thinking about it a bit more than usual or whatever. Do you want to talk about what's going on? What we usually find is that people, it's either a mistake and they said, oh, did I click that button? I meant to click 0. Or that they appreciate that somebody is monitoring it. We don't find that we really get into people using it as a way to access services in a crisis, because they also have their risk management plan. They know to phone their local assessment team or A&E or GP out of ours. So it can be very personalisable. And one thing that our clients say that they particularly like about Silvercloud, two things, is that that's asynchronous support. So you don't have to be online at the same time as your therapist. You can access it whenever you want. The therapists like that as well, because if they get a DNA, they can be catching up on their Silvercloud. And also that once a person finishes their Silvercloud treatment, those resources are available to them for the next 12 months. And our clients find that quite reassuring. Because if you think about face-to-face CBT, usually people leave with a bit of a relapse prevention pack that goes in their drawer, then goes in the next drawer down, then the next drawer down, and then they have a clear out and throw out a load of papers with that in. They have the same access that they have to Silvercloud for the next 12 months after they've finished using the package. I'm looking down at the Silvercloud people hoping, but they don't do it. That's what we were assuming. So the resources are there for them for 12 months, and lots of people find that reassuring because they're not really ending therapy, they're just ending the online check-ins from the therapist. As I said, it's quite a efficient way to deliver low intensity therapy. So with regards to outcomes, do people know what recovery rate means in IAP? So I'll mention it. IAP measures recovery. At every session, the client has to fill in the PHQ, which is a depression measure, and the GAD, which is an anxiety measure. And they have to start at above the cutoff on those, so in clinical caseness on either of those at the start of therapy, and below clinical cutoff at the end of therapy on both of them. The reason that it's either in both is that people often come along with anxiety problems. You treat the anxiety problem and it goes away, so they start going out more and they find out they're quite depressed. Or you treat the depression, they start going out more and they find they're quite anxious. So we have to be, the bar's set quite high for IAP services, so you have to start above the threshold and below it at the end. In all the CBT trials, the definition of recovery was an either or. That if you're in a depression trial, as long as your depression was treated, your anxiety could be through the roof. You were a success in that trial. So they've set the bar quite high in IAP terms. So with regards to recovery rate, this slide's a wee bit old, and then it's almost a week old now. So we've got some new data in this. Our recovery rates locally. Other services perform just as well as we do. I'm not trying to blow North West Boroughs trumpet, Our overall year-to-date recovery rate, so we've had 611 people since 1st of April this year use Silvercloud, and our overall recovery rate year-to-date is 49%. And that we have 3 services using it, and there's quite a range in those services. So the service that's been using it the longest, the service that started about a year and a half ago, their recovery rate year to date is 56%. The national target's 50, and what we find is most step 2 interventions are hitting around the 50 mark. So the service that's been using it the longest has a recovery rate of 56 year to date, and the service that's been using it for only about 4 or 5 months, their recovery rate's 45%. So we found that the longer you use it, the higher your recovery rate, and that's quite obvious, isn't it? It's about therapists getting used to it and patients getting used to it, and therapists not offering it as an inferior alternative, actually selling the benefits of it. One thing that we found that was quite interesting was that the age group that got the most out of Silvercloud, any guesses as to what it might be? Sorry? Yeah, 65 to 74-year-olds. Their recovery rate was 67% compared to... no. Yeah, that's right. We find that it's around the same proportion of each age group that use it. So as many 65 to 74-year-olds choose it proportionally as 18 to 64-year-olds. Obviously, there are fewer 65 to 74-year-olds presenting to services. We know that's an issue, but proportionally, they're as likely to choose it as the younger people, but they're more likely to get better than younger people. And that's not just with Silvercloud. Some of the national data say that they're better at psychological therapy than younger people, that once you engage older people with psychological therapy, they're more likely to recover than younger people. With regards to men and women on Silvercloud and our services, the male recovery rate's 53 and the female recovery rate's 48. So there's no significant difference between men and women as to how well they do on Silvercloud. So you can see that the recovery, so for example, in one of our teams, Silvercloud is more effective than one-to-one face-to-face therapy. So you're certainly not losing anything clinical quality-wise. With regards to user engagement, this is quite difficult to see, but these are things like I found the module interesting, it was relevant to me, it was helpful to me in some way, and it supported me to make progress towards my goals. The response rates tend to be in the strongly agree. So people, once they use it, find it helpful, or report that they find it helpful. Their recovery is as good as face-to-face one-to-one therapy. And also, this is quite an interesting figure on the right-hand side, is that users log on to the system approximately 11.8 times when they're using it, and they spend 25 minutes per session. So if you think about that, if someone is in face-to-face one-to-one therapy in an IAP service at step 2, they get usually 6 half-hour sessions with a client. With Silvercloud, they're actually engaging with the therapeutic material for 11 half-hour sessions. So they're actually they're using the therapeutic techniques more than they do, or engaging with them more than they do in individual therapy. What patients like about it are things like anonymity. You don't have to, so for example, an IAP service, in trying to make them readily accessible, we've brought therapy into community venues. So for example, one of our services is in the local swimming baths and the council gym, where you go in, the entrance to the left is the gym, the entrance to the right is psychological therapies. What we found is a lot of people don't like that. Whether we like it or not, there's still a stigma around mental health, and people don't want to be seen coming out while their mate comes out of the gym in their activewear, them coming out of the therapy services on the right-hand side. So lots of people don't want people to know they're accessing therapy. This means they can access an effective therapy from wherever they like. They don't have to ask for time off work. They can do it in their lunch break on their computer, and it's quite flexible, and having that time to review the content, of not having to sit in a therapy session and take everything in that the therapist is saying and understand it instantly. They can take their time over it. So that's some of the feedback we've got from users. With regards to where we're going with it in the future, Silvercloud has been tested well tested in the primary care field. And some of the results that they quoted us recovery rate wise, we're realising in real time in our IAP services. So recovery rates over 50 it is very achievable in an IAP service. It's also possible to use Silvercloud in secondary care mental health services. There have been 2 pilot studies done using Silvercloud in community mental health teams. Exactly the same packages. It's not CBT for psychosis. It's the panic, the sleep hygiene, anxiety, depression modules. And what they found was they're as effective in secondary care as they are in primary care if there's a bit more support added. So so for example in Silvercloud, when you come to primary care, if you're on Silvercloud, that's all you get from us. You don't get therapy alongside it, you don't get a key worker and things like that. You get a Silvercloud therapist and access to the package. When it's been piloted in secondary care, what they found is provide the package to them, but also provide additional support. So maybe 2 check-ins a week, 2 reviews a week, and a key worker to sort of maybe phone the client each week and touch base with them. So we're toying with the opportunity of embedding that within our psychological pathways in community mental health teams. Because one problem we have is we've lots of people who, for example, under shared care have to be seeing a psychiatrist regularly for medication, and that kind of makes them inappropriate to be discharged to primary care, and there's not much psychological therapy available in secondary care, not as much as there is in primary care. So if a community mental health team or recovery team or whatever type of team it is makes Silvercloud available to its clients, it can access those low intensity therapies. Also, what we found when we scoped this with our secondary services team is we've lots of clinical psychologists doing very basic work with people, doing basic work with complex people. So they were doing panic work, they were doing avoidance work, they were doing anxiety, depression work, when really that could be done in a package like this. So with regards to future opportunities, that's one of the roads we're investigating. Also, with regards to long-term conditions, the big thing over the next few years in IAP services is rolling out psychological therapies to people with long-term conditions. So IAP services currently have to see 15% of people who are depressed or anxious in the country. That target's going up to 25% over the next 3 years, with no promise of any additional money. And one of the targets we've been set is that 2/3 of that increase has to be of people with long-term conditions, so diabetes, COPD, heart disease, and things like medically unexplained symptoms. So Silvercloud's perfect for those types of people. So that's somewhere else we're thinking of going in the future. And that's my spiel over.